All these steps. A relatively complex area, but probably one of the most common areas that patients will injure. If we take a little look at some of the foot anatomy, we have large bones and small bones. And as we put pressure onto our foot, it will help distribute the weight across your foot. And so depending on how strong or weak or how much attention or ill attention you have given to kind of your foot posture or some other things will help determine that weight distribution. And so one of the things that I like to point out first is, can't see it on these images, but one of the injuries that is most common is inversion ankle sprain. And part of the reason why is you can see your tibia right here and the medial malleolus right here. It doesn't give a lot of coverage all the way down, whereas on the lateral side, you have a hard, bony structure that protrudes a little bit further distal onto your foot, and so it doesn't allow as much eversion or outside as much as you can put your kind of sole in towards your midline. You can't do as much motion towards the outside. We have some big structures here. We have our calcaneus, our heel bone. We have our tarsal bones, our navicular, medial, intermediate, and lateral cuneiforms, our cuboid, and our talus. Our talus touches or articulates with your tibia and fibula. And then you have metatarsal bones and phalanges. So you have your first through fifth metatarsals, your first through fifth proximal phalanges. You have second through fourth intermediate or middle phalanges, and then first through fifth distal phalanges. You will notice that the first toe only has a proximal and a distal as compared to the other toes. Most of what I will use ultrasound for is our lateral ankle sprains, and sometimes maybe even a suspicion of a break at the fifth metatarsal. It's typically, that's the majority of the volume that you're getting.
Yeah, the outside, but like Mitch had said, the outside of the ankle is just, it's loose. The inside has got all kinds of ligaments on it, and that's why you don't see a lot of, if you actually sprain this way, if you do an inversion, eversion sprain, you need to get more imaging than an ultrasound, because that means Dak Prescott comes to mind immediately, because when he did that to his ankle, the whole thing, you're going to see bone and everything else coming out. This doesn't happen. This happens all the time.
So here we can see the lateral ankle. We can see some of the ligaments. Probably the ones that you will see patients sprain the most is this anterior talofibular ligament and the calcaneofibular ligament. Rarely will you see a patient sprain the posterior talofibular ligament. And you might even see patients with a syndesmosis sprain, right in here, or a high ankle sprain. If you're spraining ligaments between your tarsal bones and metatarsal bones, there's probably other things going on rather than just a simple sprain. There's a lot of force. There is an injury where patients can sprain some of these ligaments between the tarsals and metatarsals. It's called a Liz Frank injury. Typically, it's seen in people who like get thrown off of their horses as the classic one, because it was like a French general in Napoleon's army who fell off his horse and had a what looked like a regular ankle sprain, but because of the mechanism, you're pulling the tarsal bones are moving anteriorly while the metatarsals are staying stable, which isn't typical, and so you're putting more stress on these ligaments and possibly spraining them. But that injury is relatively rare in patients. I've only seen it once or twice in, how long have I been doing this? 4, 5, 6, 7, 8, 9, 10, 13 years. Plantar fascia. So on the bottom of your foot, between your calcaneus and around your metatarsals and proximal phalanges, is the attachment of your plantar aponeurosis or plantar fascia. Long, thin band of tissue. You might see patients who have plantar fasciitis. It's the inflammation of this fascia, this long band of tissue. We can see this relatively easily on ultrasound because it's relatively superficial, and it helps keep the arch of our foot nice and arched. Let's maintain that. I like a bridge. Another view, here's a plantar view. So we're looking at the bottom of the foot. You can see it going all the way from the calcaneus all the way up to the base of these proximal phalanxes. And you can see all of the intrinsic muscles of the foot. So all the muscles that are inside of the foot essentially attach on different structures on the foot, as opposed to extrinsic muscles where it's attaching on the foot and then also attaching somewhere else outside of the foot. All right, so we're going to start with plantar fascia first. I would like you all to, we have 5 probes, so you're getting in groups of 4. So get into a group and we will image one of your group members' feet.
Oh, I think we should do.
Why is it okay. Hold on. I have to solve a problem right now. All right, I got this working. Finally. So who is my last group?
Well, I'm just getting ready. I'll just tell you on the ultrasound. When you're looking at the screen, now this, sitting ultrasound and doing UV. That may be what you're familiar with. Or if you're supposed to be getting ultrasound, there's a first question. So, but we use it for in training and orthopedics, or physical medicine. We use it to look at musculoskeletal issues. It's an amazing tool to do that. It's as accurate as an MRI in a lot of cases. Spine, it won't see, but foot, ankle, shoulder, elbow, you can take a quick look and see what's going on. Last year in the class, I know we had some guys in the back that had all kinds of issues. Remember that? But it's looking at the screen. One thing is the beam of that ultrasound is not the whole width of it. Okay, that would make it really easy to do. The beam is only the size of a credit card that comes through the middle of that probe. So when you're scanning, you're not getting a whole big picture. You're getting one little slice as it goes through. The other is the top of the screen is always the skin surface. So when you're looking at the bottom of the foot for the plantar fascia, yeah, this part of the plantar fascia, the skin surface will be at the top of the screen. There's a feature to turn it upside down. Orientation. When you're scanning, check and see which way you're going on the screen, because there's a notch on there that corresponds to the left side of the screen. When you're doing this, and that's part of the challenge of learning how to do ultrasounds. When you're moving like this, is the picture going that way on the screen? Is it going the same way on the screen? So just kind of play around.
Okay, cool.
And always use lots of gel.
Well, iPad. Yeah, there's. I have to do it on my phone. All right.
Right? Actually, actually, no,
Recording in progress.
Just wait and do this. And gel, be careful, gel gets all.
you did not, you don't get it.
Oh, you guys did.
It'll be
And what you put in your lap is for. It's now on the body. Done the program because it played us. Oh, God. Okay.
All right. So. You have some. Gel. Oh, dude. I'm here with you and me. Yeah. So I want you all to look at what we're doing. I'm gonna have Michaela put her foot up like she's doing, she's a big executive in a meeting. We placed plenty of gel on the probe itself. Like Ms. Noble said, we are looking at the slice of the credit card. On your screens, I want you to look at where that B, that blue B is in the circle. And I want you to find the blue dot on your ultrasound probe. Those are going to be the same size. So wherever that little dot is on your probe is where that is on the screen, so you can help orient yourself. Next thing we're going to do is we're going to look at the plantar fascia in longitudinal view. So if we think about the beam is right here, I want to go the same direction as the ultrasound probe is going. It's the same way as the plantar fascia is going. So what I'm going to do is I'm going to take 2 fingers on either side of the probe, and I have my other 3 fingers to help support me. A little too high. Yeah, no, there you go. So then what I'm going to do is I'm going to place the probe on Michaela's foot, and I can see immediately that very bright line right there on the kind of middle of my screen there. That is going to be her calcaneus, and then the parallel fibers that are just superficial to that as I move towards her toes is going to be the plantar fascia. So you can see right there where Ms. Noble pointed out, there is the plantar fascia. We can even see the attachment right there on the calcaneus. And so then as I move longitudinally, I can see the plantar fascia, and I could potentially see, now I'm getting past it, so I see some bones a little bit deep at about that 2 mark. And then as I come forward, or come towards her toes, excuse me, we get into heads of the metatarsals, and now we're kind of all in musculature.
Did you have her just go ahead and move on your toes while he's doing that? See, moving. So that's how you can tell where you are too. The nice thing about ultrasound is it's dynamic. It's not just a static thing, like if you have an X-ray or an MRI. So you can tell the different layers. You've got a fat pad, you've got fascia, you have flexor tendons. You can tell where you are by the motion. The other, when you start this, and Mitch has got his right, you'll see numbers off to the side. If it's anything above 3, use your finger off to the side of that and move it to 3. If it's on 8 or 9, you're not going to see it. That just means you're looking very deep. So move your finger up along the side of the screen to make it go to 3.
All right. I want you all to practice this now.
I will lay it down right there. Yeah.
Hold on.
Recording in progress.
Oh, you guys.
That's I think I'll do this.
All right, folks, so you've seen the plantar fascia, and so now what I would like to show you. What I would like to show you is a patient with plantar fasciitis. So you can see right here, here's the patient's calcaneus. Right here, and these are the attachments, and you can see the difference in size in the plantar fascia. So this one is inflamed, it is more hypoechoic, so it is darker as compared to their asymptomatic side. And we can see that inflammation right there on ultrasound, and you can have a patient move throughout because it is dynamic. All right. Achilles tendon is what we're doing next. The Achilles tendon is a combination of tendons between technically three muscles. You have three calf muscles, your medial and lateral heads of your gastroc, and your soleus. Your soleus is the deep calf muscle. Gastroc is the more superficial calf muscle. They all, if you want to get really technical, you group them all into the triceps surae. I don't do that. Most providers don't do that. If you really want to talk with an anatomist, they'll correct you. So we have this big, thick tendon that then inserts once again on the calcaneus. And we can see once again if this tendon is damaged or torn or inflamed relatively easily. It's very superficial, it's thick, it's easy to see on ultrasound. The next picture that I have, pathology. So here's what a normal Achilles tendon looks like. I think this is my Achilles tendon. We have the calcaneus right here, and we have this thick band of tendon. We can see the parallel fibers coming off of the calcaneus right here. And here's the key. Here's this is a longitudinal view of the Achilles. And I think I have one more on the transverse view. Yes, I do. And so we can see right here, there's a nice grouping of tendon. It's all the same brightness. So it's isoechoic, and it's a transverse view of the Achilles. And yes, that is what. So now look at your group's Achilles.
We need some more gel.
So our notes.
There you go. All right. Amazing, man. Oh, yeah. It's so much like this. It's all like no. Alright. Storm and long axis. Yes. Where Oh.
Yeah, oh yeah, well, I was, yeah, so far.
See if someone. A little hot. Go back. So that whole some of these dude, it sounds like really right there. So you just like hires for the bottom.
It is.
Look at the thing on that. Look at that. Look at the my knees are so bad. Hold on, one second. Someone put out like a max.
Yeah.
It's like.
Right.
It is.
Oh. Yeah.
Well, chili.
All right, folks, so. So now that we have looked at normal Achilles, we can see a tear. So in this patient, they have a partial thickness tear of their Achilles. They're looking at a longitudinal view in these images. Looking at a longitudinal view in these images. On this side, this is more lateral. We can see the tear right in here. And then as we move more towards the middle, we can see a little bit of tear here. And then the medial fibers, we just see a little tear. So it's not a full thickness tear, but it is a partial tear in the Achilles. And so then if we also look in the transverse view, we can see the hypoechoic area right here. We can see that tear there. Any questions on Achilles tears? All right. Last one, lateral ankle. This one is, I think, probably the hardest to master. Because of all the different structures around. So we're looking at calcaneofibular ligament first. We can go in a longitudinal view, and you can see a normal calcaneofibular ligament here versus a symptomatic one here. A patient is either inflamed or torn. Goes from the fibula to the calcaneus was the easiest positioning for this one.
I don't think you looked at the fascia.
Yeah,
Yeah, but that way you just move the foot.
and so we're sitting kind of cross-legged there.
Oh, you did it. I was thinking just.
Just straight up. All right.
Actually, maybe on the chair.
On the chair like we did Achilles. All right, so Janine, can you look at mine and walk us through? Let me steal your chair. Gather around, folks.
I don't want to get off.
I don't know. That jump. Yes. I'm going to. What? That's what I'm doing right now. All right.
Good hamstrings here. All right, so fibular malleolus through here, we know the ATFL runs this way. Okay, you're gonna look at that next. The CF runs this way. So you're gonna go right from fibula down to calcaneus. So locate your bone, and when you're scanning, you always want to give yourself a bony landmark. If you start in the middle of something, you have absolutely no idea where you are. So fibula. On top there. Calcaneus, I'm pointing on here like you can see what I'm doing. Is there a way to? So you can point out what we're.
You'll just turn around.
Yeah, that'd probably be good.
Your foot goes to long off over there.
Right, so fibula to the left, the bone at the top, and if you can palpate a bone, it's going to be at the top of the screen. We get physicians who ask these dumb questions, these guys who went to school forever for anatomy, and it's like, okay, is that the femur or some other bone that's, if you can palpate it, you're going to see it at the very top of the screen. So that will be your landmark there. And that was not an offense to physicians. My dad was one, and I've just worked with him far too long. Anybody physician dads in here? Okay, good. Oh. Well, we could say what we want then. Okay, so fibula to the left, calcaneus to the right, and the ligament, again, it's not going to be real clear, but you have a ligament that runs from calcaneus over to the calcaneus. This is.
It's mine too pathologic to see.
Yeah, you're making this hard. What we generally do in this is to look for the perineal tendons, which are, this is just real laggy, is the problem.
Mhm.
Just because of what happens. Okay, can we go to the ATFL?
Yeah.
Do you mind? This one, if you're okay, skipping it, that one's tough to find. Okay, so ATFL, and that is the most commonly sprained ligament. If you guys ever sprain something, it's chances are it's going to be this ATFL. How many of you sprain ankles? Yeah, pretty much everybody. It's not an issue until you've done it a lot, and then the ankle gets very loose. So fibula to the left. There we go. Talus to. Okay, do you have a normal foot? Should we get, anybody got a normal? Is this one better?
Who has not sprained their ankle?
Yeah, there we go, much better. So fibula to the left, you'll see it on the top, the talus to the right. And there is a ligament that runs, this one looks more normal, that runs across the top from the fibula over to the talus. Let's see if we can get some motion going here. Yeah, you're not loose here. Is that other one just real loose?
This one?
Yeah. Right there. Okay, does somebody want to be brave enough to point out the bones up there?
Michaela, point out the bones for me.
The one on the left
One on the left.
will be the fibula. If you could just find the bone up at the left, that bright white, higher up toward the top of the screen.
Left.
Left.
There.
Very good. Okay, then the other one, if you go back, the one to the right that you first point, that's the talus. So this is why it's called the anterior talofibular ligament. There is a ligament that runs right between the two. Good.
All right, go
Okay.
find it.
Good luck.
Thank you.
Yeah.
Yeah.
Yeah, the CF is just. Yeah, well, and you're bony.
That's our.
I hate that. Yeah, when you have to go from one thing to another.
And every single, not the same.
Oh. Wow.
All right, folks, we can look at a ATFL ligament sprain, so we can see the relatively thin and parallel fibers in a normal ATFL, and then you can see more hypoechoic structure, more black and gray in a symptomatic ATFL sprain. We can also see, this is the image I took of a patient where I found a fibular fracture. You can see the discongruity in the bone right here on that fibula. Very hairline fracture. Sometimes we're able to detect fractures on ultrasound that aren't very apparent on X-ray because of just how thin that we're looking at, how thin of a slice we're looking at of the structures. On X-ray, I saw this patient's X-ray. It was very hard to see, if not impossible. So then what we also have was tibial stress fracture. Once again, you can see an area of hypoechoic structure, hypoechoicity right here on the surface of the tibia. And you can see a little bit of break in the bone right here versus their asymptomatic side. It's very smooth. There isn't as much swelling. Swelling on ultrasound, remember, it shows up essentially dark or black. And then we have what I use ultrasound the most for is medial tibial stress syndrome, where the fascia from the soleus attaches onto the medial part of your shin on your tibia. You can see just ever so slightly a little bit more space, a little bit more darkness, a little bit more hypoechoicity versus on their asymptomatic side. It is virtually not present at all. So symptomatic and asymptomatic on the same patient. Do I have another image? No, that's it. So when we are scanning the medial tibia, right here, our shin bone, I like to go in a longitudinal view down the bone. That should be relatively easy for you all to do right now. Go for it. Look at the medial tibia, and then we will let you all scan whatever you want.
That's where's that from?
Radiotopia.
Oh.
Radiopedia.